tell me as a group, it's a perfect segue, Eric, which is like, where are we going next? What are the trials that we're doing now that we think are going to kind of be the emerging therapies? We're not there yet, but we're over the next. Marcia, there's some combination of mTOR and kinase inhibitors. What's that story?
So we did some data from the sorafenib trial where we actually took tissue at the time of progression, and we saw that the progressing tissue actually was upregulated had higher activity of AKT pathway activation. And in fact, we just had a paper accepted where we actually showed the histology, did quantitative immunohistochemistry. And what that data basically showed, at least in that setting, is that if you're higher than the median as far as nuclear AKT expression, you're less likely to get a response. And so that coupled together with the fact that we had some patients who after sorafenib went on combination of a VEGF and an mTOR inhibitor, anecdotally had done really well. We shared a patient that had that. We started a trial, we actually named it after her, called Lindsay's trial. And that trial actually showed that when we took patients at the time of progression, and I chose that intentionally because there was no point, in my opinion, when you're going to get a year to sometimes 2 years on sorafenib alone. I didn't need to add toxicity up front. But at the time of progression, we added in everolimus. And we showed that after progression, you could get another 13.9 months. And so that's 14 months, and that actually wasn't even the final data cut. So that's a significant amount of benefit by adding in an extra agent. And interesting because usually you stop the agent that doesn't work. But what's really clear, and we haven't really mentioned today, is heterogeneity. There's tumor heterogeneity. Some cells were responding still to sorafenib, and some of them really responded to the mTOR inhibitor. And it turns out if you do one or the other, you have progression if you do either alone. But now you put them together, and now you get this whole additional year and a half. Great for my patients, and it really actually, interestingly, adding the everolimus in at that point added almost no new toxicities. We had I don't think we had any grade 3s, or very, very few grade 3s, like handful of them. Ridiculously low numbers for a combination that should have been much more toxic. So
exciting new
yeah,
therapy.
so I think combination with mTOR inhibitors is one way to go. And we're going to do that now actually with the lenvatinib. We have a lenvatinib everolimus study going forward too.
Eric, let me ask you about the BRAF story. BRAF story and BRAF inhibitors in melanoma is a huge winner. I mean, it's a dramatic responses. We've got BRAF and thyroid cancer. What's the story of BRAF inhibitors there?
So, so there has been a phase 2 study that's been completed, and the response rate is pretty acceptable. So you see response rates between 30-35%, depending on whether it's first line or in second line. So it's not as good as melanoma, but at the same time, it's pretty good. You know, there's definitely different things about different cells that have BRAF mutations that make, it's not everything's the exact same. You see melanoma is different than thyroid cancer, that's different than colon cancer, and different than lung cancer. And, what may be, ways to try to improve what we may see in a thyroid cancer cell line, maybe looking to see what other things are being upregulated and what are the pathways of resistance that you might see from BRAF inhibitors. So from Jim Fagan's lab, we saw that there's upregulation of the HER3 pathway, and that at least in the lab, when you combine the two together, you end up seeing a much better response. Other mechanisms that people are looking at is trying to just do a better job inhibiting the BRAF pathway, such as adding a MEK inhibitor. And there is a randomized study going on right now that's looking at BRAF inhibitor versus combination of BRAF and MEK. And there might be other things to that story as well, better BRAF inhibitors which are trying to be developed. So there are things about trying to look at what are the mechanisms of resistance, inherent resistance for these tumors, and trying to maybe do a better job with the combination of in actually allowing better responses and longer responses to treatment.
Naifa, if I get out of the BRAF pathway and the MEK, Dr. Google says immunotherapy is great for every cancer. I looked it up on the way over.
Really?
Yeah, this is great. I have no idea. But where are we with immunotherapy? Should we be thinking about that?
Yeah, so not a day passes by without a patient coming into our clinic and saying, give me that cure, give me immunotherapy. That is the cure. I've heard about it, I've read about it, it's in all these magazines I read. Okay. So, obviously with immunotherapy, the goal is to use the patient's own immune system, upregulate it, fight the tumor. And there are beautiful responses in many cancers. I would say if you look across the board at immunotherapy in all cancers, you get anywhere between 20 and 40% of patients where they'll get phenomenal responses, like complete responses, and these patients do very well. But obviously that leaves 70 to 80% of patients who just don't respond, and trying to figure out who are those patients that are going to respond. There's lots of ongoing studies in other cancers, and trying to figure out who can benefit from the immunotherapy. So the way I explain it is that in thyroid cancer, we need to learn from those other cancers and what's already been done before we just put patients on these drugs, because there are a lot of subset of patients that it's not going to work in, or what's the right way to do it. So that, they've looked at the immune cells in differentiated thyroid cancer, medullary thyroid cancer, and anaplastic thyroid cancer. There's a group at Anderson, Ramona Dadu, and Maria Cabanillas that are looking at it with the immunotherapy platform folks. And in differentiated thyroid cancer, we don't see that many immune cells. And so we worry that those patients are not going to be able to respond very well to immunotherapy. We've put a few patients on phase 1 trials, and we haven't had that many great responses. So the question is, how do we upregulate that immune system so that immunotherapy can work and we can have those phenomenal responses? So some of the things that I think are going to be looked at is, do we give that TKI first? Whether it's lenvatinib, sorafenib, any of the tyrosine kinase inhibitors, or even a BRAF inhibitor, boost up the immune system and then give the immunotherapy. Maybe that'll work better. But we'll have to biopsy those patients to see if the immune infiltrate went up. Because PD-1 expression hasn't been very promising in a lot of tumors to say that is a predictor. So we just got to figure out first the biology and who it's working before we just put immunotherapy into the limelight. So that's personally why I don't put patients right away into immunotherapy. The other is, what they're doing similar in other tumors is looking at, do we give the patient a little bit of radiation, boost the immune system, and then give immunotherapy, the abscopal effect. And so those are things that need to be figured out. What's the right role in thyroid cancer? So I think there will be a role of immunotherapy in differentiated thyroid cancer. I just think we got to figure it out first before we owe that to our patients before just putting them on the trials, unless they don't have any other options. Right. They've exhausted everything else. There is, Brian Haugen's going to be leading a study looking at a PD-1 inhibitor with lenvatinib in combination. That's not going to be sequential, but that'll be one thing to be looking out for. That may give us some sort of a signal, as to whether that would be working or not. And should it be small volume tumors that go on, patients who have small volume tumors that go on this, or the rapidly growing ones? And where does the more poorly differentiated / anaplastics, should we start with those? So I think there's a lot that we don't know. I think there's definitely a role. We just got to figure out where and when.